Thank you, Senator Murray, and I know you have an important engagement, and I appreciate your extra effort in being here early. The 340B drug pricing program was created by Congress in 1992 to help qualifying hospitals and clinics that treat low-income patients. Don't want to turn over my coffee in the process of all this. The program requires drug manufacturers that participate in Medicaid to provide discounts on prescription drugs or treatments, including treatments for cancer, diabetes, or HIV, to qualifying hospitals and clinics. The hospitals and clinics may then provide the drugs at the reduced price to low-income patients, or they can sell the drugs at a higher price to patients who have insurance and keep that money and use it to provide care to low-income patients or for other purposes. According to the Government Accountability Office, approximately 40% of all hospitals in the United States participate in the 340B program. In just the last 5 years, the number of hospitals and treatment sites participating in the 340B program has nearly doubled to almost 38,000 in 2017. So today's hearing will focus on two things. First, what is the purpose of the 340B program, and is it fulfilling that purpose? And second, should there be changes in the law so that program can fulfill its purpose? First, we need a better understanding of that purpose and why the 340B program exists and how it's being used. Today there's confusion about that, confusion about the program's goals and requirements because Congress did not make clear in the 1992 law creating it what the purpose of the program actually is. The closest the law came to defining the purpose is a House of Representatives report to which Senator Murray referred, which accompanies the legislative text, and which says the program was created, quote, to permit covered entities to stretch scarce federal dollars as far as possible, reaching more eligible patients and providing more comprehensive services, unquote. This has usually meant helping low-income patients afford their medications and health care, and to ensure that qualifying health centers can provide care to the most vulnerable patients. Here's an example of 340B in practice from St. Thomas Hickman Hospital in Hickman County, Tennessee. The hospital participates in the 340B program. A Hickman County resident with diabetes was unable to afford the $332 cost of insulin and went into a diabetic coma. He was told about the 340B program at St. Thomas Hickman and was able to buy the insulin for $8.90. According to St. Thomas Hickman, the 340B program has also helped the hospital expand mental health care services and reduce emergency room visits. The Health Resources and Services Administration, the Health and Human Services agency that oversees the program, estimates that hospitals and clinics purchased $12 billion of discounted prescription drugs through the 340B program in the year 2015. The House Energy and Commerce Committee has just estimated that just a year later, in 2016, the 340B hospitals and clinics spent more than $16 billion on discounted drug purchases, up from $12 billion, a 30% increase. So 340B hospitals saved about $6 billion in 2015, according to those figures, by buying prescription drugs at a discount. That $6 billion represents about 1.3% of the total purchases of prescription drugs in the United States in 2015. In other words, about 1.3% of the total amount spent on prescription drugs in the United States is devoted to the hospitals and clinics that qualify for the 340B program. Hospitals will point out that according to the Department of Health and Human Services, hospitals spent more than $50 billion in 2013 on uncompensated care. That's service to patients that is not reimbursed. Hospitals and clinics use the $6 billion in savings that they generate through the 340B program to help offset the money they spend in uncompensated care. On the other hand, we also know there are instances where 340B hospitals and clinics may not be using the savings directly to help low-income patients afford their medications or provide care. There's no limit in the statute that says what hospitals may or may not spend the money on, so some have criticized this, such as Dr. Rena Conti from the University of Chicago, Dr. Peter Bach from Memorial Sloan Kettering, who found that, quote, the 340B program is being converted from one that serves vulnerable patient populations to one that enriches hospitals and their affiliated clinics, unquote. This is why there have been reports, including from the Health and Human Services Office of the Inspector General, the Government Accountability Office, the National Academies, and from the House Energy and Commerce Committee, that suggest that while the 340B program does provide real benefits, there needs to be more clarity around what the program allows and does not allow. For example, one 2011 report by the Government Accountability Office recommended increased oversight of the program and that the Health and Human Services Administration, or HRSA, issue and finalize guidance on the definition of a 340B patient. Last year, the National Academies recommended more oversight and regulation to ensure that the program directly benefits patients. I hope today we can learn more about the program and how it might be improved so that hospitals and clinics can continue to provide low-income patients with help to afford their health care. Now, each witness, I'd like to ask the four of you if you could summarize your comments in about 5 minutes. We'll then allow more time for questions and conversation with senators. First, we'll hear from Bruce Siegel, the President and Chief Executive Officer of America's Essential Hospitals. Dr. Siegel leads AEH, a trade association that represents more than 300 safety net hospitals and health systems. Second, we'll hear from Ms. Lori Riley, the Executive Vice President of Policy, Research, and Mentorship at PhRMA. Ms. Riley leads the Policy and Research Department at PhRMA, a trade association of brand drug manufacturers. Third, we'll hear from Sue Veer, the President and Chief Executive Officer of Carolina Health Centers, Incorporated. Ms. Veer leads Carolina Health Centers, Incorporated, which serves as the medical home for over 27,000 patients in the state of South Carolina. And finally, we'll hear from Joseph Hill, the Director of the Government Relations Division for the American Society of Health System Pharmacists. Mr. Hill leads the Government Relations Division for that trade association that represents 45,000 member pharmacists, student pharmacists, and primary technicians. We welcome again all of our witnesses, and Dr. Siegel, let's begin with you. Welcome.
Thank you. Chairman Alexander, Ranking Member Murray, and honorable members of the committee, thank you for the opportunity to speak today about how the 340B program supports our hospitals and the many people and communities they serve. My name is Dr. Bruce Siegel, President and CEO of America's Essential Hospitals. We represent 325 hospitals and health systems that form the backbone of the nation's healthcare safety net. Our members are public and nonprofit hospitals across the nation, from the Appalachian foothills of Tennessee to Center City, Philadelphia, to Louisiana Bayou, to Utah's Great Salt Lake. They are the trauma centers and burn units and neighborhood clinics for these and hundreds of other communities. Our hospitals are diverse, but they share one defining mission: to care for all people, regardless of social, financial, or health status. Hospitals with this mission are precisely those Congress targeted when it created 340B more than 25 years ago. Congress's intent was explicit and clear: to protect hospitals from runaway drug prices. What was a problem then remains a problem today. Remember that 340B grew from an urgent need for action when drug prices surged as manufacturers reacted to Medicaid's rebate program. We are no less at risk now than we were then. Skyrocketing drug costs threaten our hospitals and patients.